we concentrated with the same, I'm going to show the same images, okay? We concentrated how the aortic arch develops. Now we're going to go to the internal carotid artery. We, in early days, we usually think carotid artery is one tree, goes to into the external carotid artery, and then internal carotid artery. Okay? Actually, formation of the internal carotid artery is connections of a lot of different embryonic processes. Okay? If you see, sometimes you may see different variations of the carotid arteries or absent carotid arteries. This is carotid artery, just end up ophthalmic artery. Okay? No connections to intracranial portions. Let's look at it, how internal carotid artery forms. Okay? It's the same image. You can see this ventral aorta, dorsal aorta. Okay? Third aortic arch, first, second, third aortic arch, and this is fourth aortic arch. Okay? Sixth aortic arch is developing now. From that process, it does not stay as always as it is. Okay? This is a diagram Pierre made for second publication of with Carell and Alex Berenstein. When they're making second edition of surgical neuroangiography, he made this diagram to explain the processes, how it goes. Okay? And actually, this program is, you can see the ventral aorta, dorsal aorta, first, second, third aortic arch, and this middle one is called ventral, longitudinal ventral neural arterial axis. Okay? So this is separate diagram of this specific segment. Okay? For me to understand a little bit better, I put in the colors. Okay? Some colors, you can see this ventral aorta continuing, and segment of dorsal aorta, you can see the stump, but this is actually, I explained to you, regression of dorsal aorta between third and fourth aortic arch. Okay? Now we have a ventral aorta becoming later on, explained to you, okay? And this is third aortic arch, second, first aortic arch. This is primitive hypoglossal, parathalamic 1, parathalamic 2. This is third intersegmental arteries. Okay? So we have this diagram illustrating this green is trigeminal artery. The one we connecting from trigeminal artery connecting to the ventral longitudinal arterial axis. The one connecting to opposite side, called 14, is primitive maxillary artery. We'll go over what this means. Okay? From that process, from this stage, we saw a lot of changes going on. Some pruning, new angiogenesis, new things developing. Okay? First process, okay, pruning process going on is first aortic arch. This first aortic arch is disconnected from ventral aorta. Okay? And then second aortic arch connection to ventral aorta disappears too. Okay? So this connection disappears. Okay? 35 days, what we have is, you can see the regression of the connection to the ventral. This is ventral aorta. Okay? This is dorsal aorta. Dorsal aorta, you can see this continuing third aortic arch. Okay? And I mentioned regression of this dorsal aorta at third and fourth aortic arch. So from the ventral aorta, you have a third aortic arch in continuing become more primitive internal carotid artery. Okay. Second aortic arch is giving off hyoid and stapedial artery system. Okay. And that is connecting a little bit of remnant of this ventral aorta of distal first and maxillomandibular, the region, they connecting each other, okay? And becoming, you can see the ventral aorta with the higher stapedial artery system connecting to area of maxillomandibular range. Okay? This connection we'll talk about later on when we talk about the external carotid artery. So, the third aortic arch and fourth aortic arch is completely separate. We mentioned about developing of subclavian on the aortic arch system. Now we're going to concentrate more distally what it happens. Okay? So if you look at it, okay, this second aortic arch giving off higher stapedial artery system and this higher stapedial artery system giving one branch going to the orbit, so-called supraorbital branch, and second branch is connected to maxillomandibular range. Okay? Philip mentioned about the maxillomandibular branch of higher stapedial artery system. And then once this connection occurs, okay, once this connection from the ventral aorta to second aorta arches, maxillomandibular branch, this does not need it anymore, right? So that portion regresses, just giving off primitive artery of carotid tympanic artery. Okay? Then remaining intracranial portion is remaining as middle meningeal artery. Extracranial portion, which was maxillomandibular branch, is become internal maxillary artery. Okay? That's not one point of this topic. Okay? So what we see is internal carotid artery is not one just a tube. And even the one tube, but connections of different embryonic segment. First part is third aortic arch. Okay? This is cervical portion of the internal carotid artery. From the third and second aortic arch, this segment become intra-petrous segment, okay, up to this foramen. From that point, you go to ascending portion, okay, horizontal ascending portion. This is becoming ascending portion, okay, and this is intracanavicular segment of internal carotid artery. This segment, okay? And then there's a trigeminal artery. Later on, we'll talk about. And the trigeminal artery is regresses, and this become cavernous, intracavernous portion of internal carotid artery, and then we go to intracranial internal carotid artery. Okay? So it is connection of 7 different segments. This is what? Third aortic arch. Number 2 is between third and dorsal aorta of between second and third aortic arch, and then first and second aortic arch, then first aortic arch to trigeminal artery origin, then trigeminal artery origin to dorsal ophthalmic artery origin, and dorsal ophthalmic origin to primitive ophthalmic artery origin. From there, you have caudal and cranial rostral division of the internal carotid artery. So we have 7 different segments. Okay. So from there, we have gradually become 7 intersegmental arteries. There are many embryonic vessels we see. We mentioned about a lot of embryonic vessels. Okay? Those embryonic vessels are here, we just to talk about. Okay? We see what that is. Okay? We mentioned hyostapedia artery. Hyostapedia arteries comes from remaining part of second aortic arch. Okay? And we'll talk about what it is. Okay? Hyoid artery develops about 9 millimeter stage from dorsal aorta, from the second aortic arch. Stapedial artery is given off from there develops. Okay? Dorsal territory of first aortic arch is, I mentioned, the second aortic, the maxillomandibular area is taken over by this stapedial artery system. Okay? And it enters middle cranial fossa and become supraorbital and maxillomandibular branch, which is intracranial to extracranially developing maxillomandibular branch. Okay? Look at this case. This case is, I have the only one is many years ago. You can see the common carotid artery injection. Internal carotid artery, there's a dysplasic changes. But where the internal maxillary is coming from? Okay? There's no connection between the external carotid artery to internal maxillary artery. Internal maxillary artery is coming from internal carotid artery. So this connection didn't happen. Okay? Because this connection didn't happen, so this is persistently filling internal maxillary artery from internal carotid artery. Okay, this selective injection shows internal maxillary artery is coming from internal carotid artery. Okay, as well as middle meningeal artery is also same origin. Okay. But normally, this hyostapedia artery system gives the corticotympanic branch. Okay, corticotympanic branch is the one that goes to the tympanic cavity from the carotid canal. Okay, Petrus branch of middle meningeal artery. This is called the superior tympanic branch. Okay, that's remaining part of stapedial artery going intracranially to before it divides into supraorbital and maxillomandibular branch. Okay. Mandibular branch is the one remaining part of first aortic arch. Okay. First aortic arch, it gives off the branches in normal adult, and horizontal branch we call the median artery. Inferior branch is going through the foramen lacerum. It's a nasopharynx, that's a mandibular branch. Okay? This is mandibular branch once goes through the bone. Body of sphenoid bone is median artery. The one goes down to nasopharynx is called mandibular branch. Okay? These are one of the examples. Okay? You can see this branch goes down nasopharynx. Okay? In connecting to internal maxillary artery through the anastomosis near the Eustachian tube. In this case, you can see the branch going anteriorly and connecting to distal internal maxillary artery. This is median artery. Median artery you don't usually see because it's going through the bone. Okay, small vessel through the bone. It's, unless it is enlarged, it's difficult to see. Okay. This is one case. You can see the injection of internal carotid artery. You can see the mandibular branch goes down to the nasopharyngeal area and anastomosis with the internal maxillary artery branches. Okay, you can see this branch going backward, the same branch. So especially when you embolize with the juvenile angiofibroma, you have to pay attention. This branch can exist. Okay. This is again partial persistent stapedial artery system. You can see the middle meningeal artery is coming from apart from the stapedial artery systems. Okay? So this is giving off, mandibular branch is giving off middle meningeal artery. Okay? This is another good example. You can see beautiful demonstration of internal carotid artery is connected to middle meningeal artery. Okay? The other embryonic vessels we may see in clinical practice is persistent hypoglossal artery. Hypoglossal artery is originate from internal carotid artery, go through the hypoglossal canal and become vertebral artery this way. Okay? This is going through the hypoglossal canal. This is another example from Ranipinsky, and he had the internal carotid artery going through the hypoglossal, and this is directly connecting ICA. Okay? Not instead of a vertebral artery going through the ICA. And this is another pattern of persistent hypoglossal canal. Okay? So ascending pharyngeal artery, okay? Initial hypoglossal artery become ascending pharyngeal later on. So easy to understand hypoglossal ascending pharyngeal artery giving supply to the cerebellum is this way. This one, external carotid artery is giving vertebral artery. Vertebral artery originating from external carotid artery. This is pro-atlantal 1. Go through the C1 foramen, okay, and become vertebral artery. This is pro-atlantal, persistent pro-atlantal 1. This is another example, CTA. You can see this is occipital, external carotid artery, okay, and giving off vertebral artery through the C1 segment. This is remaining persistent pro-atlantal 1. This one, external carotid artery, and this branch is going through the C2. C2 interspace and become vertebral artery this way. This is pro-atlantal 2. Okay? We're going to talk about trigeminal more details later on, but trigeminal artery develops a 4th millimeter and regresses at 6 weeks, connecting to aortic system to groin, ventral longitudinal arterial axis. Ventral longitudinal arterial axis is initially 2 separate axes, but later on fuses together, making vaginal artery. Okay? And the spinal artery. Okay? Trigeminal artery always connects to the vertebral artery between superior cerebellum and ICA origins. Okay, usually this is the one it connected that way. And some of these trigeminal artery may just disconnected and supplied ICA only, or some are ICA-PICA territory. We'll talk about more details of how it remains. Premotive maxillary artery supplies olfactory region in initial early stage, very early, and regresses rapidly after 4th week and originates from the 4th and 5th junction. Okay, may connect together with trigeminal artery. But later on, remember, this become posterior hypophyseal artery. Okay? This is the one passage diagram. You can see this is the primitive maxillary artery. Primitive maxillary artery initially supplied this region and then regresses very rapidly and later on. Okay? And in adult, you always see supply to the posterior hypophysis. Okay? Posterior hypophyseal artery is a remnant of primitive maxillary artery. Okay? Sometimes primitive maxillary artery may persist. This you can see between connection between right and left internal carotid artery and cavernous segment. This branch is the only one goes intracellular. Okay? There's no other branches. The other branches are more posterior, but this goes through. If you have any vessel going through the intracellular regions, this is remnant of primitive maxillary artery. Okay? This is a case, you can see the one internal carotid artery agenesis, we'll see it again. And then this is reconstructed through the primitive maxillary artery. The other vessels, we'll talk later on about dorsal ophthalmic artery, which is originating from cavernous segment of internal carotid artery, go through the superior orbital fissure and supply this orbit. Ventral ophthalmic artery is ophthalmic artery originating from anterior cerebral artery. We'll talk about in ophthalmic discussions, okay? And Pierre mentioned, this is his book, second edition. More distal, less variations. If you want to distal close to the target, variations is less. However, source supply, more proximal. Proximal sources, just like we discussed internal carotid artery development, 7 different segments, you have more variations, so-called normal variations. Okay? We'll talk about what kind of variations we have. Okay? I put it on title as internal carotid agenesis, but we'll talk about what happens if each segment disappears. First segment disappears. What other sources would be closest source of reconstituting distal tube? One of the things I thought is, if segment 1 disappears, the one is second aortic arch may be reconstituting internal carotid artery more easier. What you call so-called non-bifurcating is wrong to me known as non-bifurcating internal carotid artery. Look at this case. Common carotid artery injection, there's a little stump. Distal internal carotid injection, distal stump. But all the branches are coming from one trunk. Lingual facial and internal distal external carotid artery, occipital, all this one trunk. And you can see the 3D stump, okay, stump. Must have been connected before. Huh? Another case. Stump, one trunk giving off facial, okay, internal maxillary artery and internal carotid artery, all this got one trunk. Right? Must have been connected before and regressed somehow. There are another interesting case. I got it from this professor in Seoul National University. You can see common carotid artery, you have a 2 internal carotid artery duplication. So this is supposed to be regressed, but did not regress, and instead this is connecting together, okay? Becoming duplicated internal carotid artery this way. Okay? So this is example of regression of the first segment. As I show you this one, I also believe this regression of third aortic arch, first segment, so persisting this way, okay? It has to separate origin of the internal carotid artery external. This is another example of separate origin of internal carotid artery and external carotid. This is external, internal carotid artery going this way. Okay? In case second segment disappears, regresses first. So there's no other outflow, so first segment is also disappears. Okay? In case this disappears, what? you have hypoglossal ascending pharyngeal artery giving off, connecting to stapedial artery system called, what do you call it? You must know. Aberrant internal carotid artery, what do you call it? Right? This internal carotid artery is going through middle ear and catches the carotid canal. Okay? This is what I believe this connection is going through this way. Nice 3D images, movies. Okay? You can see the internal carotid artery is going through the middle ear and joining cavernous canal this way. Okay? Another example. Typically you have acute angle like this. Okay? This one, right carotid, left carotid. This is old angiogram. I think it was some 80s. I did it. Bilateral aberrant internal carotid artery. Unfortunately, because of tinnitus, we went to ENT surgeon. The ENT surgeon saw something behind the eardrum. So he decided to make a biopsy of that. This is after biopsy. So he did internal carotid artery biopsy this way. Okay. Another example is a double channel reconstitution. This is going through the middle ear, and second one is going to ascending canal of the internal carotid artery. I think there's two channels illustrated in Pierre's book. I think this is one of the examples of two channels, going one into middle ear, the other one into probably cervical canal. This is another example. You can see two channels of reconstitution. This going to the middle ear. Second one is going to the ascending cervical canal near the foramen lacerum. Okay. This one is normal carotid artery, and additionally you have additional aberrant course of the internal carotid artery is reconstituting this way. Okay. Segment 3, agenesis. Segment 3. This is 1, 2, segment 3. The other source of anastomosis can be either connection to mandibular region through this ascending pharyngeal artery. Okay? Okay? Look, this is not aberrant course. Okay? You can see the reconstitution of the internal carotid artery is the horizontal segment near the foramen lacerum region, and this is going through, I believe, from mandibular branch, external carotid artery to, this is more complex, ascending pharyngeal artery reconstituting close to the foramen lacerum. There's a two connection to the inferior lateral trunk cavernous segment, and this is Peter segment is reconstituting. Is probably from ascending pharyngeal artery giving off a superior pharyngeal artery, superior pharyngeal artery branch gives off the carotid branch that connecting with the recurrent artery foramen lacerum of internal carotid artery. That's what I think is anastomosis channels. And I spent many hours to interpret this, but that was my conclusion of this. Okay? How about agenesis of this fourth segment? Fourth segment goes out. The other close source of the reconstitution is trigeminal or primitive maxillary artery, right? This is the only case I know is from the Pierce book. Okay, this is trigeminal artery giving internal carotid artery reconstitution. This is example from John Scott, and this case you have internal carotid artery agenesis in this child, but internal carotid artery is reconstituted through the branch going through the cellar. I said the primitive maxillary artery is the one which goes through the cellar. And this is the one reconstituting internal carotid artery this way. And this is another case you saw earlier from Ronnie Pisky. You can see the primitive maxillary artery reconstitution. Okay? Segment agenesis, fifth segment. Okay? Fifth segment is uniquely, Pierre also mentioned as a retrobenevolent, okay, is good as well. And specifically in these locations, somehow they make this channel of this anastomosis to reconstitute. This is one case you can see. CT scan shows carotid canal, but absent carotid canal on the right side. And what you see here is multiple channels, okay, and reconstituting distal internal carotid artery this way. There's some branches coming from ascending pharyngeal arteries, also reconstituting branches. This is again case I had many years ago. You can see the internal carotid artery, red tail-like reconstitution to the distal internal carotid artery. This is from the Kominami. You can see the multiple sections. Okay? And this is from Assam Medical Center. Dr. Lee gave it this case to me. And you can see the different channels reconstituting distal internal carotid artery. Stage 6 agenesis. If the stage 6 is agenetic, there's no internal carotid artery. Either cavernous or distal internal carotid artery reconstituted through the IMA or other collaterals to inferolateral trunk or ophthalmic artery anastomosis. Okay? This is where sixth segment disappeared. Okay? The ophthalmic artery may come from distal collaterals, which is that this is PCOM, and retrograde filling of the ophthalmic artery this way. Okay? And ophthalmic artery is filling from the distal segment. You actually don't need it, ophthalmic artery at that level. This is another case, no internal carotid artery. Ophthalmic artery is filling from distal, reconstituted distal internal carotid artery through the PCOM. Okay? And this is another case. Okay? You can see this ophthalmic artery is filling only the retina. The rest of the contact of the orbit was reconstituted through this inferolateral trunk and through the remnant of the dorsal ophthalmic artery. This is extreme case. Internal carotid artery not persist, but distal internal carotid artery and ophthalmic artery reconstituted through the collaterals of the internal maxillary artery, through this dorsal ophthalmic and ventral ophthalmic and anterior cerebral artery, and portion of the left internal carotid artery reconstituted through this, what it is? Primitive maxillary artery. Okay? Segment 7. Okay? If segment 7 regressed, small ICA and ophthalmic artery, that's the usual pattern what we see here. This is one example. You can see internal carotid artery, ophthalmic artery. This is another case where I saw previously. This is again another case. Okay? Bilateral. You can see the bilateral, agenesis of the seventh segment. You can see the small ophthalmic artery. There's another reconstitution of the small ophthalmic artery. Okay? So far, to prepare this talk, I look at it was a genetic internal carotid artery. I had 35 cases in my collection, And there was bilateral case was a 7, so total 42. Most of it, interestingly, is segment 6. Agenesis is most of it. I don't know why, but that's among my collected cases of agenesis in the okay. Thank you very much. Any questions?